Good evening everyone. Myself Dr. Pratik Patel, working as a trained cardiac physiotherapist in UNMICRC Institute of Cardiology and Research Center. As a part of physiotherapy continuous education, today my topic is Icu Physiotherapy for cardiac disease. Contents of my topics are introduction of ICU, types of ICU units, types of heart disease, contraindication for physiotherapy in ICU, monitoring, adverse effects of ICU stay, problems in ICU, winning criteria. In objectives, we will see assessment of patient, goals, treatment techniques used in ICU by physiotherapist. First, we will see the introduction. Intensive care, also known as critical care, is a multidisciplinary and interprofessional specialty dedicated to the comprehensive management of patients having or at risk of developing acute life-threatening organ dysfunction. The primary goal of intensive care is to prevent further physiologic deterioration while the underlying disease is treated and resolved. In ICU, we are seeing patients having acute organ dysfunction. So our main goal is to prevent further physiologic deterioration. This is a picture of an ICU unit. Now we will see the definition of ICU. An intensive care unit is an organized system for the provision of care to critical ill patients that provides intensive and specialized medical and nursing care and enhanced capacity for monitoring and multiple modalities of physiologic organ support to sustain life during a period of acute organ system insufficiency. In ICU, we have monitors and other modalities like ventilator and other infusion pump and all to support life during acute organ insufficiency. Types of ICU units are medical intensive care unit, surgical intensive care unit, pediatric intensive care unit, neonatal intensive care unit, post-operative intensive care unit, neurological intensive care unit, and trauma intensive care unit. Now we will see the types of heart disease which are commonly seen in ICU are coronary artery disease, heart arrhythmias, heart failure, heart valve disease, pericardial disease, cardiomyopathy, and congenital heart disease. Contraindication for physiotherapy in ICU are unstable angina, resting systolic blood pressure greater than 200 mm of mercury or resting diastolic blood pressure greater than 110 mm of mercury, moderate to severe aortic stenosis, acute systemic illness or fever, uncontrolled atrial or ventricular arrhythmias, uncontrolled tachycardia greater than 100 beats per minute, symptomatic congestive heart failure. Now we will see the monitoring. Monitoring, we have two types: non-invasive monitoring and invasive monitoring. In non-invasive monitoring, we have temperature, heart rate, respiratory rate, blood pressure, and oxygen saturation. This is a picture of an ICU chart in which we can see for vital parameters, ventilator parameters, blood gases, hemodynamics, urine output, chest drainage, and infusions. In invasive monitoring, we have arterial blood pressure, central blood pressure, pulmonary capillary wedge pressure. This is a picture of devices used in ICU and monitoring. Now we will see the adverse effects of ICU stay. The most common adverse effects are bed rest and immobility during critical illness result in profound physical deconditioning, skeletal muscle weakness in the intensive care unit, development of neuropathy or myopathy contributes to weaning failure, respiratory dysfunction, prolonged ventilator dependence, bed sore, and ventilation and perfusion mismatch. Problems in ICU are decreased lung volumes or compliance, decreased gas exchange, decreased mucociliary clearance, weakness of peripheral and respiratory muscles, and increased work of breathing. Now we will see the main objectives are assessment of the patient, goals and treatment techniques used in ICU by physiotherapist. In assessment of the patient, we will see the general observation, in which we will see the patient position, whether the patient is lying in supine lying or side lying. Watch for respiration, that patient is spontaneously breathing or on receiving ventilation via endotracheal or tracheostomy tube. Watch for vital signs, that is temperature, BP, RR, HR and SpO2 as shown in the monitor. We will see for the tubes and lines the patients are having, like CVP line, peripheral line, chest tubes and catheters. Whether the patient is well conscious or not, read the case papers and daily orders, type of mode of ventilators and FiO2, that is fraction of oxygen, which is shown in the picture, and drugs. Examination of the chest in mechanically ventilated patients. First we will see for the inspection, in which we will see chest movement, whether the movement is symmetrical or not, clubbing as shown in the first picture, cyanosis. There are two types of cyanosis, like central and peripheral. Central is commonly found in tongue and lips, and peripheral is found in extremities, like that shown in the second picture. AP and lateral chest diameter, kyphoscoliosis, which is shown in the last picture. In palpation, confirm all the inspectory findings like tenderness, rib fracture, crepitus and tracheal deviation. In percussion, we will see for the dullness, normal or hyperresonant sound. In auscultation, we will see the breath sound, whether it is vesicular or bronchial. Also watch for added breath sounds like rhonchi, wheezes and crackles. Goals are pain relief, to prevent accumulation of secretion, to mobilize and remove secretion, to teach proper method of breathing pattern and effective coughing and huffing, to mobilize the thorax and shoulder girdle, and to teach the postural awareness, to teach relaxation, to improve functional capacity by exercise training program, to advise the home program. Objectives of chest physiotherapy are clearance of secretion from large and small airways, improve ventilation to areas of local lung obstruction, to reduce incidence of post-operative respiratory infection, morbidity and hospital stay. Treatment techniques used in ICU by physiotherapists are positioning, mobilization, manual hyperinflation, percussion, vibration, shaking, cough and huff, suction and breathing exercises. First we will say for positioning, aims are optimizing O2 transport through its effect of improving ventilation, perfusion matching, increase lung volumes, reduce work of breathing, minimize the work of heart, enhance mucociliary clearance. Handling a conscious patient, 2 to 3 people are needed to turn a patient, ensure sufficient slack in lines and tubes, inform the patient, if possible disconnect the patient from the ventilator, turn the patient smoothly and check the lines, patient comfort and observe monitors. Second is mobilization. Early mobilization plays an important role in ICU. This technique helps to maintain or restore normal fluid distribution in the body. It reduces the effect of immobility and bed rest. It includes limb exercises, neck exercise, moving or turning in bed, sitting in the edge of bed, standing transfer from chair or bed, and walking. Third is manual hyperinflation. It is one of the technique where there is involvement in disconnecting the patient from the ventilator and inflating the lungs with a large volume via a manual resuscitator bag. Bagging can be used as a technique to hand ventilate a patient or during physiotherapy. Manual hyperinflation can be given by using ambu bag. This is a picture of an ambu bag where we can deliver oxygen via O2 tubing. Postural drainage position. Definition is: postural drainage is the positioning of a patient with an involved lung segment such that gravity has a maximum effect of facilitating the drainage of bronchopulmonary secretions from the tracheobronchial tree. It is based on the concept of gravity assisted mobilization of secretions and transport it for removal. This is a picture of various postural drainage positions. Apart from this, we are not using head down position as it is not advised for cardiac patient. Contraindication are hemoptysis, severe pulmonary edema, congestive cardiac failure, large pleural effusion, pulmonary embolism, cardiac arrhythmias, recent myocardial infarction, and recent neurosurgery. Fifth one is percussion and vibration. Are manual technique used to increase clearance of airway secretions. Chest percussion is performed with slightly cupped hands applied alternatively to the chest wall with a quick relaxed flexion and extension of the wrist. Percussion. Medication to reduce pain is given prior to treatment. In pediatric patients, percussion is given by using hand, fingers or face masks. Frequency is 100 to 480 times per minute. Contraindications are lung abscess, bronchopleural fistula, hemoptysis, rib fractures, osteoporotic bone, tumor area, pulmonary embolism, low platelet count, or if the patient is receiving anticoagulation therapy, unstable angina, chest wall pain, example thoracic surgery. We cannot give over the anterior aspect in these patients. We can give over the back. Vibration. Vibration is performed manually by vibrating or compressing the chest wall. Pressure is applied in the same direction in which the chest is moving. Vibration is applied throughout the expiratory phase, and the movement is brought about by contraction of pectoralis muscle and biceps. As the muscles contract to bring the hands towards each other, vibration takes place. Shaking. As with vibration, shaking is applied throughout the expiratory phase. The physiotherapist places his hand suitably on the chest wall with her elbows slightly bent but the body well positioned over the patient. As the patient poses as at maximum inspiration, physiotherapist should vigorously shake the chest using her body weight and continue to shake through expiration. 8 is suction. It is used in unconscious patient and in patients with depressed cough. Ideally, the catheter diameter should be the half of the size of the tracheal tube or endotracheal tube. In adults, we are using 10, 12, 14 and 16 French gauge, and in pediatrics, we are using 6 and 8 size. Monitor vacuum pressure 100 to 120 millimeter of mercury for adults and less than 100 millimeter of mercury for children. No suction pressure is applied during the insertion of the catheter to avoid mucosal trauma. Catheter should be advanced until a cough reflex is elicited or some resistance in trachea is felt. Complications of suction are infection, bronchospasm, tracheobronchial trauma, hypoxia, atelectasis, cardiac arrest or cardiac arrhythmia. Now we'll see the winning criteria. If the underlying pathology is reversed or under control, patient should be fully awake, alert, conscious and obeying commands. Stable hemodynamics should be there. Mean arterial pressure should be greater than 60 millimeter of mercury. No significant abnormality in chest X-ray, normothermia, adequate in urine output, adequate pain control, adequate tone and power, ABG on CPAP, comparison with last ABG like FiO2, SpO2, PCO2 and electrolytes and lactate. Ninth is cuff and huff. Both cuff and huff are forced expiratory technique. First we will see for cuffing. Cuffing is a forced expiratory technique performed with a closed glottis, and huffing is performed with an open glottis. Breathing exercises. Goals are assist removal of secretion, improve respiratory muscle strength and endurance, increase thoracic mobility and tidal volume, promote relaxation, teach the patient how to deal with shortness of breath attacks, improve patient's overall functional capacity. Types are diaphragmatic breathing, segmental breathing in which we have lateral costal, posterior basal expansion and apical expansion. Pursed lip breathing, patient slowly inhale through his nose and gently exhale through pursed lip. It increases tidal volume, improve exercise tolerance, decrease respiratory rates. Fourth one is breathing control. It is a normal tidal breathing to promote relaxation and prevent hyperventilation. While teaching breathing control, avoid full expiration. Expiration should be controlled but not forceful. Position is side lying, head elevated, leaning forward. Effects are relief of dyspnea, improve vital capacity, improve ventilation perfusion. 11th is incentive spirometry. Incentive spirometry, also referred to as sustained maximal inspiration. Incentive spirometry is designed to mimic natural sighing or yawning by encouraging the patient to take long, slow, deep breaths. This is accomplished by using a device that provides patient with visual positive feedback when they inhale at a predetermined flow rate or volume and sustain the inhalation for at least 5 seconds. This is a picture of volume oriented and flow oriented spirometer, in which we can see in the down one is flow volume oriented spirometer, in which we can see indicator, mouthpiece, flexible tubing and piston, and when the patient inhale through the mouthpiece, the piston rises. As the piston rises, the indicator which is shown at the right should also rise, and it should be between the two arrows. If it does not stay there, it means you are breathing too fast or too slow. Purpose are to increase transpulmonary pressure and inspiratory volumes, improve inspiratory muscles performance, and re-establish or stimulate the normal pattern of pulmonary hyperinflation. When the procedure is repeated on a regular basis, airway patency may be maintained and lung atelectasis is prevented or reversed. How to use? The patient is instructed to hold the spirometer in an upright position, exhale normally, then place the lips tightly around the mouthpiece. The next step is a slow inhalation to raise the ball in flow oriented or the volume oriented in the chamber to the set target. At maximum inhalation, followed by a breath hold and normal exhalation. Indications are presence of pulmonary atelectasis or condition predisposing to the development of pulmonary atelectasis, when used with upper abdominal or thoracic surgery, prolonged bed rest in patients undergoing CABG, patient with inspiratory capacity less than 2.5 liter. Contraindications are patients who cannot be instructed or supervised to assure the appropriate use of the device, patients in whom cooperation is absent, or patients unable to understand or demonstrate proper use of the device, confused or delirious patients, or who are heavily sedated or comatose, patients who are unable to deep breathe effectively due to pain, diaphragmatic dysfunction, or opioid analgesia, patients unable to generate adequate inspiration with a vital capacity less than 10 milliliter per kg or an inspiratory capacity less than 33% of the predicted normal. Last one is passive and active exercises. Limb exercises like passive range of motion and active assisted range of motion are performed in ICU patients. It helps to improve joint range of motion, functions, muscle strength, soft tissue length. It decreases the risk of thromboembolism. IRR and TENS can be given for relief of pain. Thank you.